Dear colleagues and friends, it's truly a pleasure to address your group today. I would like to share with you some concept that I believe we can say are really new concept in regard to treating tooth wear. Our understanding about risk factor and their impact on the loss of tooth structure, either from a chemical standpoint or mechanical standpoint, are now really much better understood. And that has led to implement new concepts, which are a lot more detailed and specific to the nature of tooth wear risk factors. Also to another important element, which is that wear rarely impact just every teeth of the mouth to the same extent. So we need to address that quite important factor as well. So now we evolve, as I said, towards a very specific approach. I wouldn't say tooth by tooth, but nearly, which take into consideration all biomechanical and functional factors that provide for the patient an answer, a treatment approach that is a lot more specific and effective. Also to minimize the need for tooth preparation and optimize the longevity of restoration, taking into consideration the specificities of different biomaterials which we can use for treating tooth wear. So let's go over this presentation, and we'll see each other later on for a discussion.
Tooth wear actually can present itself in many different ways, and the type of wear process, the extent of wear process goes from relatively limited to moderate and severe wear extent. And of course, just looking at those few clinical images allow us to understand that we'll not be able to treat those different patients with the same solution. And I would like to go over treatment strategies first, and then we'll address some specific protocols that give you an idea how we can approach the various forms of tooth wear. The first element is to understand that we cannot in fact consider tooth wear as being just a single factor. I'm just trying to take a little bit better laser pointer, sort of. We found in the past that it would be either erosion or abrasion attrition, so to speak, chemical or mechanical wear process. It's very different actually. Most of patients present a combination of the two types of risk factors. Just the incidence or prevalence of each risk factor is different. Not only different in between cases, but different over a lifetime. So the extent and relative prevalence of both types of risk factors might change over life. So if you see the patient in that area of his wear process development, or here, or here, or here, you might end up with different solutions. In a relatively recent consensus publication, at least there was one major change in our approach on which everybody agrees, is that we must be more conservative. That will have a tremendously positive impact on the long run. I also started to use quite a long time ago. That was the first publication that I did with my brother, 1996, in Ph.D, a journal that no longer exists, but it was some conceptual change in our approach, which for this bulimic patient involved a combination of direct and indirect restorations using composite and ceramics, what I call today hybrid approach. And in this book that I wrote with a few colleagues and experts that was published in 2023, I was, of course, developing all those concepts, this couple of decades experience in treating tooth wear that I would like to summarize in this presentation. The first strategy we have, and hopefully that we can improve in the future, is preventive. It means nightguard to protect the teeth in case of bruxism, Botox eventually to reduce the muscle contraction forces and reduce the volume of muscles, and pH control that of course involves many different forms of preventive measures. On the other side, we have the restorative. I intentionally not use prosthetic because prosthetic is a little bit sounds quite negative or very invasive by nature. So restorative involves extensive or full coverage of occlusal surface or palatal or facial using indirect, composite, CAD/CAM, and high-strength monolithic ceramics in general. And in between, we have this group of interceptive protocols which make use of composite as the main biomaterial. And we can use composite in different ways: direct freehand, direct molding, single molding, or multiple molding, or the shell technique, which is a molding technique used in the lab. Let's look at the first case to illustrate interceptive therapy approach. You see this patient, late 30s. We have a significant tissue loss here because of a combination of erosion and attrition or bruxism. And the question is for us, are we going straight with a full mass classical rehabilitation, or can we do something else? Actually here, following proper functional and occlusal analysis and a full wax up of this case, I made basically direct restorations, no prep, to restore both arches. That was in 2010. And when the patient is coming back 8 years later, you see that we start to observe some relapse of the wear process. But here, talking with the patient, we understood that the patient didn't change anything in his life habits and diet, consuming too much fizzy drinks, and not wearing the nightguard that he had received. So in a way, it is a failure with the compliance of the patient, but still 8 years later, the situation remains relatively under control, and we could actually renew the case. Renewing means actually, or refreshing if you like, means that we go back with application of composite with no need to redo everything, just to add again fresh material. The main preparation in this case is sandblasting using a multifunctional adhesive system, and adding again, of course, it goes over normally the whole arch, and then we can move forward, hopefully catching more attention of the patient regarding compliance. Because at the end of the day, whatever technique we use, with zero compliance of the patient, we usually expose ourselves to some sort of failures. But with composite, the beautiful advantage of composite is that you never get severe failures. This is what we call minor failures. Now to come back to the options we have, starting with anterior restorations, based on the amount or severity of wear, we can use different protocols: freehand, incisally, on the palatal side, molding, both incisally or on the palatal side, veneering approach up to crowns in very severe cases, and using combination of composite and ceramics. No monotherapy is to be considered today. And this is unfortunately what social medias make us think, is that the whole mass should be treated with the same material in the same way. And this is a very, very limited understanding and simplified approach that is not going to work for our patients and us. When it comes to pathology teeth, same approach, depending on the amount of wear: freehand, molding, full molding, shell technique, which is a molding technique in the lab, or indirect CAD/CAM, and once again, combination of composite and ceramics, depending on the situation. And as I said before, the hybrid options basically is somewhere in between interceptive and restorative prosthetic. So it is a combination using the best of those two different strategies. So now let's go and explore freehand protocols and which are the basic steps for freehand protocols. We start, of course, with clinical observation. We see here a case with limited to moderate wear in the upper arch. Observing teeth will allow us to understand the risk factors. So what do we deal with here? We deal with mainly attrition. As soon as dentin is being exposed, you will get abrasion. And here we had also an erosion factor, cofactor, but attrition was the main risk factor. We need then to relate the amount of wear to the patient's age. That's a crucial element. And then we, of course, need to integrate aesthetics. Aesthetics, by the way, is being the main reason why patients consult. The impact of wear on smile configuration is the key factor for the patient to look for information and support. Then we must, of course, integrate this in our analysis. Then, with either a conventional analog waxing technique or digital wax up, we will define where we need to make modification here, mostly on the lower back teeth, but also to understand where we need to do some compensation on the upper arch, because the approach that we have for interceptive protocols is going to be mostly no prep. So if you add on one side, you will need to compensate on the antagonist to maintain even balanced occlusal contact. This will, of course, imply an increase in the vertical dimension of occlusion. And we know from different publications, especially some literature reviews from Abduo, that we can go up to 5 millimeter interincisally and we'll get basically systematically adaptation of the system through neuroplasty. But it's rarely indicated. It's rarely possible to increase so much the video. And in fact, there is a very interesting paper from Calamita and co-workers, and they describe this video increase with 1-2-3 relationship. And this is something that we must understand, actually, is that when you increase about 1 millimeter on the back teeth, you will get a more important opening in the front. And if you remain around CRP MIP, using mostly a rotation of the mandible, you might even get a little bit more than 2 millimeters, actually. But it's a very elegant description of the concept which we use. And in the same article, they're explaining that depending on the amount of correction that we need to do in the video, compensation will occur only on the upper or the lower, on the palatal, on the incisal. All depends on the occlusal scheme and the pre-existing anatomy of the patient's mouth. So also from a functional and occlusal standpoint, there is no single approach, single concept. It's a highly specific approach that we try to implement. So now with the classical wax up, this is still the same case we are working on. We have the wax up chair side, we have one sextant on the rubber dam, and I will go back and forth visually from the model to the mouse to build up the posterior occlusion. And you see here, this is after a session of about 2 hours maximum, probably even less. And provided we have a good visual reference, and of course we have some experience in building up posterior anatomy, you can, within a relatively short time frame, create nice anatomy. We spend 10-15 minutes on premolars, up to 20 minutes on molars, thinking that this is a single increment of composite that we work with. So we cannot, shape the composite for hours. This is the other side of the mouse, and usually in the first day we're going to complete one arch. Now we are at the stage of adjusting occlusion. You see that with minimal occlusal corrections, we are getting quite even occlusal contacts. We are not at the end of the occlusal adjustments, but with just a couple of minutes, provided we have a precise occlusal scheme given by the wax up, this technique is quite effective. So now you see the before treatment in the center, the post occlusal buildup, left and right hand sides, and a little time later you see that the occlusal anatomy has not really changed from the situation on the rubber dam and after adjusting occlusion. All is about controlling anatomy. That requires, of course, a little bit of experience and training. And I will show you a little later and share with you what can be the alternative to this approach, which is molding, full molding technique. So now you see the post-op treatment and post-op treatment for the posterior teeth. And now, of course, we need to move with the next step, which is the compensation of the video increase on the front teeth. So here we did also freehand some direct veneers, which cover the palatal surface, protect the worn surfaces, and provide adaptation for anterior guidance and occlusion. So we like to maintain anterior guidance. If you work with composite, cannon protected dynamic occlusion is a key factor because composite doesn't like shear and tensile stresses so much. So if you reduce those stresses on your posterior teeth, that will increase their longevity, reduce the risk for chipping and wear. Of course, we need to create a decently flat anatomy so that you avoid lateral interferences. And anyway, every time we increase the video, we will reduce the overbite. So it will also reduce stresses on your anterior restorations. Now we see here the 5 years follow-up. Patient is a dentist, by the way, but she did never wear the night guard because she felt so comfortable. And at the end, everything looks good. We only have a little chipping of composite here, which will be easy to correct. But we see that there is some wear of the composite. And at the end of the day, in a case like this, the restorations play the role of a permanent night guard. I'm not saying it is ideal, but sometimes is all what we can do for the patient if the patient isn't compliant enough. And now we're going to go with some more freehand protocols using, let's say, a more modern approach. So we have a patient. She's a hygienist. She's consulting because of aesthetic concerns. She feels her teeth to be very short. Proportions and dimensions are not really good anymore. And when we do our clinical analysis, we understand what the problem is. She was basically going through frequent vomiting during pregnancy, and that has led to losing completely the enamel on the palatal and also some tooth structure on the incisal edges. It's not here due to diet or lemon consumption, but just vomiting in her case. Looking at the back teeth show that we have a lot of failing aging restorations. We lost a little bit of tooth structure on some areas as well. And we finally agreed with the patient that replacing the majority of restorations will be needed. The only restoration we haven't changed is the PFM crown that the patient was willing to keep as it was placed not such a long time ago. We're going to go here with a full digital wax up. We don't use classical wax ups anymore nowadays. I would say unfortunately, because for wear cases, the visual of a classical wax up is of course very useful for us, but there are other ways we can play with digital wax ups and analyze the volume that we need to modify on each tooth. Of course, digital wax up lead to a printed wax up, out of which we can create an index and prepare our mock-up, which in this case will be an aesthetic and functional mock-up to assess the impact of increasing the video. We consider that aesthetically and functionally the situation was satisfactory. So now we are ready to move on and restore the back teeth. Just by moving from a concave anatomy to a convex anatomy that we can recreate with classical protocols for posterior restorations using composite. In this case, 2 layers of dentin. Dentin is being shaped so that we have the volume for developing enamel anatomy. The anatomy here is developed freehand, of course, always guided by the wax up, and with a little bit of painting, which we love to do. That also helps us to visualize the anatomy. It's another way to learn the anatomy. We must be, of course, very discreet. We can do a little bit more staining on the upper, probably a little bit less in the lower. And this is now the transfer, which happened here visually, the transfer of our digital wax up into our freehand restorations. Here, the size of existing restorations allowed to do everything freehand. The only 2 teeth that we considered were not appropriate for a freehand composite approach were the 2 lower left molars with relatively extensive cracks. It's something that I personally don't like to treat with composite because composite has less potential to block diverging forces. Even if you include fibers, fibers will strengthen the composite, slightly increase the stiffness of the composite, but will not have much effect on blocking diverging forces, which will unfortunately lead to progression of the cracks. We use here protocols such as cervical margin relocation, IDS, cavity design optimization, all concepts which date from the late 90s. Those are concepts we have been working intensively on in the mid 90s, and now they are perfectly evidenced. We went here, of course, with an intraoral scan, CAD/CAM, Emax restorations, and you see here the pre-treatment wax up and how we basically transferred that information to the mouse. We can use some indexes also to guide the placement of composites. I don't have the time to go into so many small details of the techniques, but of course there are many ways we can improve the reliability of our buildups in order to be perfectly in line with the pre-treatment wax up. Then we come to the buildup of the upper front teeth. We had here slight problems to maintain the rubber dam in a proper position. So we use metal strips to box basically the palatal and allow us to place the composite in a precise way along the palatal cervical margins. Then came the second step of the anterior teeth buildup, which is the incisal edges. We use a lot of molding techniques. Here, it is a freehand case. It really depends. Sometimes I like to do it freehand. I must say it is maybe not completely rational, but I do a lot of freehand because I really love to do it. So here, it was not molded. We have at the time being not increased the height of the teeth. We have just completed the build-up according to the guidance of the wax-up, a little bit of characterization, and then the build-up with palatal enamel, which was placed here with help of a soft matrix, some build-up for dentin, and a last layer of enamel. And well, provided we have a good aesthetic material and an effective shade selection process, you can do a direct build-up, literally extending the remaining tooth structure with composite. No facial prep, no veneering of the facial. And you see that we get a nearly invisible transition from the composite to the tooth structure, which is really a wonderful quality of good modern composites. I would say that maybe not every composite on the market allows you to get this kind of result, but we have a few good options. And now you see the full treatment including occlusal surfaces. I think composite is really a very, very attractive field for resolving a lot of limited to moderate wear cases. So now we're going to go toward molding protocols. I start with the first case. It's a moderate to severe attrition case when it comes to the front teeth. Our basic treatment approach here will be to raise the video by doing restorations mainly on the lower back teeth and do some more composite work on the upper front teeth, on the palatal and on the facial. You see now the path of your teeth. Now they're already at the stage of our full molding approach. We have a hard tray which has been relined with soft translucent silicone on the wax up so that we have very detailed reproduction of the anatomy. And this is at the end of, let's say, the session. Finishing is relatively simple. The protocol is relatively simple, but of course, we should not miss any of the steps. And this is the treatment on the other side. The anatomy is as good as the wax up, and today we can really get beautiful wax up made with digital technology. We go further with build-up of the lower front teeth. This is the first part of the compensation for the video increase. And then we're going to go and restore worn palatal surfaces. We can then complete the treatment with some facial veneering. In this case, it was only one part of the treatment that was done freehand. That was the facial of the upper front teeth, and everything else was molded. Now, if you look at the pre-treatment situation and the post-treatment situation, if you think about the simplicity in the way of this approach, and it's completely no prep. I'm not saying that it does apply to any level of wear severity, but for limited to moderate wear cases, if the treatment is well planned, by a combination of freehand or a little bit more molding approach, if you like, we can provide the patient with one full result. I just show you the 7 years outcome with absolutely no touch. We have unfortunately lost somehow the motivation of the patient. Hygiene is not good enough, so you get a bit of staining in the proximal here at the margin, but not so much on the composite actually. We even got here on that case less staining of the composite, just a slight loss of the surface quality, the shine of the surface, because if the patient doesn't brush regularly 2 or 3 times a day with a soft or low abrasivity toothpaste, that might be a problem. Otherwise, very little damage of the composite on the upper palatal, a little bit of loss of volume on the back teeth, but rather limited. Patient is semi-compliant with the nightguard, but again, nothing serious. And we know that after some time, usually somewhere between 7 to 10 years, we might move toward renewing, which means addition. Here I'm moving with a case that was treated with a hybrid protocol. It's a gummy smile case, a patient who is very shy. She's not happy with her smile, but she's also looking at the same time for a conservative, soft treatment approach. We have retroclination, slight retroclination of upper front teeth, some loss of volume on the facial. You see that the teeth are nearly prepped for placement of veneers. A little bit of decay on the upper incisal edges, wear of the lower incisal edges as well, slightly decayed, like on the upper arch. We have shortened arches both on the upper and the lower sides, failing composite restorations. This type of wear pattern that is typical, look at this, typical of attrition. If you only have, and clenching actually, if you only have bruxism with a larger functional, parafunctional envelope, you will get very flat anatomy. When you get very concave anatomy, well, we could say there is the lack of wear resistance of the composite, but it's not only that. Look at the natural tooth structure. This type of wear pattern is typical of clenching. So we must always think about the mechanical stresses. Lower arch shows less wear on the back teeth. We have to address, and actually we're in the process now of reconstructing the bone. This case requires imperatively to look at the X-rays to get an idea about the condition of the existing restorations. We definitely need to replace those restorations. We can't leave them in place. Adhesive interface is failing. So our treatment plan is to replace all posterior restorations on the upper back teeth with indirect approach, freehand direct on the lower, increase of the height of the front teeth, getting better proportions. Now we are at the mock-up stage. We did, of course, a digital wax up, printed the models. I suggested to go with crown lengthening of the front, the upper front incisors, which the patient was not sure to go through. So we said, anyway, we go with composite on those teeth. That can be done in the second step. But we will be able to judge after the treatment if this is an acceptable option or not. First, sorry, I'm just going back just to the previous slide. We did some bleaching before we started with the treatment of posterior teeth, following the exact same process. And This is after we completed the restorations. It's a combination of overlays and onlays made of lithium disilicate. Why ceramics here, or this type of biomaterial? It's because we need stiffness. When teeth are fragilized to a large extent, ceramics will provide the stiffness that the residual tooth structure needs, especially if you have cracks at the base of the cusp. Composite is no longer our best choice. That's something we need to really understand. Now we are finally ready to go, after increase of the video, to go with the upper front teeth treatment. This is the shade selection. This is our dentine shade guide, combination of dentine and enamel shade guide that gives me the visual control of the shade match, which is very good. And here it's a case where we did some molding. Here I molded the 4 palatal surfaces in one shot. I go with the mold, light cure very shortly, just to freeze the composite, get the composite to stay on the tooth so that I can remove the excesses with blades or spatulas. Gives me the palatal buildup and also the incisal edge, new length. I complete the buildup with some dentin on the incisal edges. You see on the right hand side already the palatal buildup completed. And here, of course, because of the amount of wear that you have seen before on the front teeth, we will do a more extensive buildup on the facial with a combination of restorative and a little bit of flow cervical, because the volume to be replaced is not very important. And with a single increment of enamel on the facial, I will complete my veneering. So I have full veneering on both centrals, partial veneering on the laterals, and just cusp buildup for the canines. Lower front teeth, they will be restored with minimal changes. We have less volume to build up on the lower front. You see here the situation. You can use an index here, or you can do it freehand, whatever your preference is. And this is the post-op situation for the lower arch. After we completed the 6 front teeth, always restoring a nice canine guidance, both upper and lower. And this is the full smile. It's not a super aesthetic case. Now you see the full arch in the posterior. Now you see how the path of your teeth look like on the X-rays. Cervical margin relocation, CDO, cavity design optimization, the lining wherever there is no need for the lining, just at least the IDS layer. And here the use of a stronger material, a stiffer material to grant actually mechanical stability of the teeth. I'm going now through just a few cases to cover the topic of maintenance and longevity, to give you an idea about what you can expect when using, especially composite, because this is actually our main topic. If you analyze failure rates provided by the literature, if you classify also the literature according to observation periods, I personally like to look at longer periods of observation. And I would take the 8 years plus data, and you see that for anterior, posterior, or mixed restorations, the failure rates basically extend from 2 to 5%. But when it comes to composite, we deal mainly with minor or relative failures, which means we can repair or repolish the restorations. If you look at the data for ceramics, veneers, and crowns, 3, 5, 10 years, we have less data, by the way, for ceramics as compared to composite in the specific situation of wear cases, bruxers. But you see that we are exactly in the same range of failure rates from 3 to basically 5%. But here the main difference is that we deal with major or absolute failures, which requires at minima we need to replace the restorations, cracks, fractures, quite often bout fractures, possibly endo complications, and sometimes even extractions. Of course, something important to say here is that we probably don't use ceramic restoration in the same situations, biomechanical situations, but it would be a wrong perception of things to believe that composite will lead to bigger failures and ceramic only to successes. It's absolutely not that. in the specific situation of wear cases. Here you see a patient, is a colleague of mine, erosion related to unbalanced diet and high consumption of fizzy drinks. We have restored everything freehand according to the wax up. This is the post-treatment view. Patient is back 11 years later. He has been wearing the nightguard, even though we are mainly here dealing with an erosion or chemical risk factor that provides, of course, less stress on the restorative material. We have renewed, patient was interested to renew the restorations 12 years later. Of course, we haven't removed the previous restorations. Again, sandblasting, multifunctional glove ionomer, and placing a new layer of material. Here, a hybrid case. It's a non-orthodontic case because actually the patient is coming from the orthodontist specialist. And the relative complexity of the treatment made the patient refuse that option. And I was asked to look at restorative alternative to the treatment. Next to the aesthetic, here a complication. You see the amount of wear. The erosion here made the entire palatal cusp to melt down. It's quite incredible how much tooth structure was lost. But you see that when you come to the molars or when you move forward, the amount of wear is not identical. Less wear on the lower. This is now the follow-up 11 years of the same case. We only had an indirect restoration on that tooth. Everything else has been restored. Freehand direct, no restoration on that molar. Upper arch. Yeah, we have small signs of wear, but in a patient who has proven to be very compliant with the nightguard and also has changed his diet. Here clearly he changed his diet. We have here the 13 years follow-up of the upper front teeth. Those are 4 feldspathic veneers. Here we have freehand composite veneers. It's a nice example, not the most aesthetic example, but one example how we can mix biomaterials. Because again, it's a completely wrong concept to believe that all the teeth must be restored with the exact same material.
Thank you very much for listening. I will leave you now in the expert's hands, if I may say, of Dr. Heike Kramer. She will be running the discussion and provide you with certainly all the answers that you might have after this presentation. That was a rather conceptual presentation, but also with, of course, illustration with clinical cases, which I really hope will address most of the points that will be covered into the more comprehensive program that I will provide at IDEA